So we've mentioned the inferior, the septal, the anterior, and the lateral regions. What actually determines why infarctions happen where they happen? Say it again?
Blockages?
Yeah, and really what it has to do with is the geography of the coronary circulation. Remember, the coronary circulation is the blood vessels that feed the heart. And in this class, as same thing as in fall term, we only need to know about a few of the large arteries, okay? So, first of all, the left main coronary artery, sometimes called the LMCA, comes out of the base of the aorta, remember that part? And it immediately bifurcates. So when you hear about the three large arteries, what we're actually talking about is not the left main, it's the two bifurcations plus the right coronary artery. So the three main arteries are the left anterior descending, also called the LAD. And I'm perfectly happy for you to call it the LAD as long as if I say to you, what's the LAD? You can answer, it's the left anterior descending. And then the left circumflex artery, which is a lot of times written LCX. And the left circumflex immediately goes around behind the posterior of the heart. In a minute we'll see, I'll flip it around and show you. So we've got the left anterior descending, the left circumflex coming out of the left main, and then the right coronary artery doesn't have that major bifurcation, because if you think about it, the left side is much bigger, so there's more big vessels. So the RCA refers to the right coronary artery, which comes down the right side of the heart and then circles around to the back. So if we look at the back side of the heart, what we'll see is that the left circumflex comes from the left side, circles around the back, and then drops down to the inferior wall. The right coronary artery circles around the right side and does the same. So if you're asked the question of, excuse me, of the three main arteries, which two perfuse a similar area, intuitively, you might answer, well, the left anterior descending and the left circumflex, but that's not correct. The two of those three main arteries that perfuse a similar area are the left circumflex and the right coronary artery, because both of them circle around the back of the heart and then drop to the bottom. So they have a lot more similar real estate than the left anterior descending. Okay, does that make sense to people? Okay, this is just a cool picture. So here are the three main arteries. Again, we're not using the left main because the left main is so short it immediately bifurcates. So the three main coronary arteries, if you look at the left circumflex and the right coronary, they pretty much perfuse a similar area, whereas the left anterior descending just goes right down the front side of the heart. Okay, real quick nuts and bolts. So, a 12 lead represents 10 continuous seconds, and each lead lasts 2.5 seconds. Numbers you need to know. So what does that actually mean? What that means is this whole piece of paper is moving through together, okay? So everything here, in fact, I think I have a little line here. Everything here is happening. Somebody have a pointer? I do. Okay. Thank you. So everything here is happening at the same time. This is the same heartbeat shown in all the different perspectives. Okay? Everything here is happening at the same time. That's the next beat. Everything here is happening at the same time. So you see it's moving through together. Okay, and so on and so on and so on. Okay, so this is how it moves through. So from the beginning here to the end there is 10 seconds, and each lead is 2.5. We have 4 leads across. Here on the bottom line we have 3 AVF, V3, and V6. Each one represents 2.5 seconds. And again, it's all happening at once. Does that make sense? Okay, again, all that's happening, all that's happening, all that's happening. Okay? Now, here's one of these stupid little things that you have to take up some brain space, and there's no logical reason, but we don't write the rules, so you just have to do it. Okay? We are used to expressing ECG time in seconds. If I say to you, what's a normal PRI, you could answer 0.12 seconds to 0.2 seconds. If you look on a pre-hospital 12 lead, I don't know if they all are, but as far as I know they all are, they will show the intervals in seconds. Unfortunately, the hospital 12 leads uses milliseconds to say the same thing, okay? So instead of 0.12 seconds, they'll say 120 milliseconds. It's the same thing. But you have to be comfortable going back and forth because you also have to be able to read hospital 12 leads. I don't know why that is. It's stupid. So 2 boxes, as we know, is 0.08 seconds. That's 80 milliseconds. 3 boxes, 0.12 seconds, 120 milliseconds, et cetera, et cetera. So one way or another, you have to be comfortable moving back and forth. Okay? So again, the printout from hospital monitors uses milliseconds. So let's look. Now, this part of the 12-lead printout is truly going to be useful to you. So you have to know how to read it. You have to be comfortable with milliseconds. So let's look at it. And in a way, it's not so difficult as it may seem, because if you look at QS duration, it says 86 milliseconds. Is that a normal QRS or not? Yeah, it is. Because anything less than 0.12 seconds, which is 120 milliseconds, is normal. And if you look at it without getting even worked up about the milliseconds, you think, well, what is a QRS? What would be the most normal place for the decimal place to be if it was seconds? It would be 0.86. You see what I'm saying? So it's not that hard to, it's not that hard. But you can't use this unless you're comfortable with milliseconds. So you need to be comfortable with milliseconds. Now, if you look at a pre-hospital, we're back to talking about the PR interval, but you look at the QRS, it's hard to read because it's been blown up in this, they put slashes through the O's. But here it's 0.08 seconds. So again, it's a normal QRS, but you have to be able to read both. Now, to repeat, we're so used to 6-second strips. And everybody knows how to calculate the rate on a 6-second strip. Unfortunately, it doesn't transfer over 100% because we now have a 10-second strip, okay? So this means we can't use the exact same 6-second method. You can always use the boxes method. That works on anything. But if you're asked to calculate the rate from a 12 lead, if somebody hands you the 12 lead and there's no printout across the top, and somebody says, what's the rate, you have to be able to do it, okay? No printout, they're just testing you, what's the rate? So either you can use the boxes method, which works perfectly well, or you can use essentially not the 6-second method, but the 10-second method, because that's what it is. Calculate the number of R to R intervals and multiply by 6. So it's not as easy because you have to multiply by 6 instead of 10. But so for example, here the rate is going to be 84, okay? So it's not something you're going to do all that much, because when you're on scene, how do we get the rate when we're on scene? Yeah, look at the monitor, or if you're given a 12 lead where the printout's still on it, look at the printout. That's a very accurate number most of the time. That's the printout, okay, you can use it. So you're not actually called upon to do that this much, but you've got National Registry ahead of you, and believe me, they're not going to give you the printout on that. So you have to be able to do it one way or another, okay? So again, okay, in this case it's going to be 72. Okay? Okay, but what's the quickest way is to read the printout. Now, if you plan on reading the printouts, which is very smart, the numbers off the printout, you got to practice doing it, okay? You know what I mean? It's like you have to say, now where is it? So here it is, ventricular rate, 71. Super, super useful, okay? And most of the time, trustworthy. Okay, so there it is. Okay, so our next little nuts and bolts topic is, what's this thing? Okay, you're going to see this if you look, unless somebody has cut it off from the 12 lead, like when they printed it out, they cut it off. You will see that at the start of every single 12 lead, and it's a calibration number, okay? So what does that mean? Okay, so let's go back for a minute and look at this one. This is a normal calibration, meaning the calibration here is normal. That's what it means. And we know it's normal because it's 2 large boxes or 10 millimeters high. If the little, and 95% of the time when you look at a 12, 99% of the time when you look at a 12 lead, the calibration will be normal. It's not something that comes up that much, but occasionally it does. And you know it's normal because it's 10 millimeters. So what that means is you can trust the amplitude of all the intervals. This is a normal amplitude. It hasn't been fiddled with, okay? The calibration has not been turned up or it's not been turned down. So this is a normal amplitude, okay? But you will have the ability to turn the calibration up or down. So why would you want to do that? So if, when you look at the 12 lead, here's normal, 10 millivolts, if it's been turned up, so everything is going to appear twice as high as it would under normal calibration, the calibration figure is going to be 20 millimeters. Usually you can turn it up twice or down half, okay? If it's only 5 millimeters, it's been turned down, okay? So why do you want to do this? And again, you won't very often. So I'm going to give you an example. This isn't the example. The next one is the example. Okay, so in this particular case, is this a normal, can you tell, is this a normal calibration or not? It is. It's 2 large boxes, normal calibration. What this person was trying to do was to really look at the P waves. They were pretty sure these were P waves, but they just wanted to get a better look. So they have these really P waves in front of the QRS. And to help themselves out, they turned the calibration up. This is what they did. Now you can tell it's been turned up, and now all of a sudden the P waves just pop up, okay? So that's one reason why, if you're saying, God, are those P waves? They're so flat, I'm not sure. If you turn the calibration up, but you've got to remember, oh yeah, the calibration's been turned up, and be sure to turn it down later when you print out your ECG. But if anybody's looking at it, they'll say, oh, this person, I don't know what they're doing, but they turned the calibration up. Okay?
The only reason I can think of to turn the calibration down happened to me, actually. It was one time where we had, I'm trying to remember exactly the situation. We had somebody who was in a very rapid, maybe an SVT or something like that. And the amplitude of the QRSs was huge, okay? Now, what is a good treatment for a very rapid SVT? Unstable. Yeah, synchronized cardioversion. Now, what does the synchronized part mean? Say it again?
Is it syncing with the T wave?
Well, it's syncing with a QRS. It's syncing off the T wave. It's syncing off the back of the T wave because it doesn't want to hit it. How do you know when you press the sync button that in fact you have synced? You'll see these little lights, and you should always check. Okay, you press the sync button. Look, are we synced? Yes, we're synced. Now we can do synchronized cardioversion. This person, the amplitude was so high, we kept trying. It was very funny, actually. I mean, the patient survived, so we were able to laugh about it afterwards. We kept trying to sync, and we kept looking, and it was like, it's not syncing, it's not syncing, it's not syncing. And finally, we realized that the amplitude was so high, it was off the, it was an old machine. It might work better with the 12 leads now. We couldn't see the little light. We couldn't tell if it was synced. So we turned the calibration down, came down, saw the little buttons, and then synchronized cardioversion. But that's the only time I've ever known why somebody would want to turn the calibration down. Okay, QRS morphology. So let's just talk about, in general, some stuff, some observation of the QRS complexes. We're going to talk about amplitude first, height. And last fall I said, oh, we don't care about the height of the QRS. It doesn't matter to us. It's all the same. And the truth of the matter is we still don't care that much, but we care more this term. So we do have to talk about it a bit. So I know that you have noticed sometimes when you look at the QRS complexes, they're really tall. And sometimes you look at the QRS complexes and they're really short. And I just kept saying in the fall, it doesn't matter, it doesn't matter. But now we're going to talk about what some of the reasons are, okay? First of all, when you hear somebody saying, oh, they have low voltage, what's the definition of low voltage? Total QRS amplitude, meaning from the very bottom to the very top. So if there's an S wave and an R wave from the bottom of the S to the top of the R, or the bottom of the Q to the top of the R, or the bottom of the R to the top of the R, total amplitude, if it is less than 5 millimeters at normal calibration in the limb leads and or less than 10 millimeters in the precordials, that's our cutoff. Anything less than that is defined as low voltage. Okay, and of course it's a bit of an arbitrary number, like all these numbers are. So why? Does anybody know why anybody might show with low voltage? Anybody have any ideas?
Force.
Say it again?
Fat.
Yeah, absolutely. Obesity, what was something over here?
Pericardial effusion.
Yep, pericardial effusion. So if there is something, so if there's increased layers of fluid, fat, or air between the heart and the electrodes, okay, it's going to come up with low voltage. What's the other type of thing why there's low voltage? In a way, this is an artifact of being able to see the signal. What's another reason that's not really an artifact? What might cause somebody, their heart, just to put out little bits of electricity?
The SA node's failing.
Say it again?
Nodes are failing, the SA node.
Or everything's failing.
Yeah.
We'll just call that. So if somebody has a previous massive MI, so there's just a lot of dead cardiac tissue and not that much that's depolarizing, you're going to come up with a less. So if somebody is in serious heart failure, That's another reason, okay?
Because, I mean, when it comes to like pacemakers, I mean, I'm sure the pacemaker is replacing,
Yeah, the pacemaker wouldn't matter,
right?
because the pacemaker would probably lead to a wide QRS, but in terms of amount of voltage, the depolarization is still, if the heart is basically healthy, except that the SA node, goes too slow, it's still gonna come up with a normal depolarization normally.
Right, so pacemaker is not relevant to voltage as much as.
Correct.
It's relevant.
To rate.
To rate.
Yeah, correct. So just some examples. Here's somebody with massive pericardial effusion. Okay. Here's somebody. This one's interesting. This is cardiac tamponade, and it's not just the low voltage, but look at the weird. And this isn't a 12 lead. These are just strips going across, right? So this is a full lead tube. Look at how every other beat is different, right? Look at this compared to this compared to this compared to this, all the way across. This is a kind of a rare thing called electrical art. You don't need to know this for this class, but when you see it, if you want to impress, the doc and the ED or something, and they hold this up to you and you say, it's electrical alternance, boy, they will pat you on the head.
Is that one of those things that's gonna show up on the NRMT exam?
I doubt it very much.
Okay.
I really doubt it very much. And it can happen with cardiac tamponade, but it is, you want to impress those guys. So here's prior massive MI, again, very low voltage. Okay, what about reasons for high voltage? What do you think?
Ventricular hypertrophy.
Bingo, that's the big one. So left ventricular hypertrophy, which is a lecture all unto its own, or at least half of a lecture all unto its own in the spring. Okay, so we're not going to really go into it, but essentially what happens is, for whatever reason, the left ventricle becomes big, okay? And there's more mass, more tissue, more electricity, okay? There's also right ventricular hypertrophy, which we don't care about. We care a lot about left ventricular hypertrophy because it's one of those things that mimics a STEMI. It looks like a STEMI, so it's a good thing. That's one of the things we're going to learn about, but not for some months.
Or I guess never know, disregard.
So this is left ventricular. This is a good example. I mean, you can see. Remember that one you said, what's that stalactite hanging down? That was left ventricular hypertrophy.
Okay.
And you can see why. I mean, look at how, these are huge amplitudes. And we'll learn about how to determine, this one almost is a neon light flashing left ventricular hypertrophy, but we'll learn about it later.
Are there congenital forms of like hypertrophy, like if your heart's?
I'm not honestly sure. I really don't know. So, don't know. Now, we have spent a lot of time in the fall discussing QRS width, and I don't know about you, but I'm tired of it, so we're not doing it anymore. Well, we will, but not today, okay? We already know all about, ventricular, IVCDs, all that. We will definitely get into it later, but not today. That being said, determining the QRS width on a 12-key lead can be a little bit daunting because sometimes it seems like the width really changes lead to lead, and you're going to need to know about that. So, for example, let's just look at this 12 lead here. If we look at, for example, V2, where we have an RR prime and the J point is here with a flipped T wave, I think even the back row can say, oh yeah, that's a wide QRS, right?
Mm-hmm.
Okay, so that one really looks wide, but then, I think on the next page I show them both. Okay, so here's V1, undoubtedly wide. But look at V5. Wow, that looks pretty narrow, okay? So what is this? Is it wide or narrow? So a couple of things. The widest QRS is always the most accurate. So one of the nice things is if you're trying to determine and you don't have the printout, somebody just hands you a QRS and says wide or narrow, you don't have to go through every lead, just skim through, find the one that looks the widest and you can use that, okay? So if you have even one lead with QRS greater than 0.12, consider the rhythm to be wide complex. And everybody knows what I mean by wide complex, right? So it's either a ventricular rhythm or a supraventricular rhythm with an IVCD, a wide complex. So in this case, even though it kind of looks like some of these are narrow, we can clearly see these are wide. So this, what we'll say is this whole thing, the QRS complex is wide, okay, the whole thing. Okay, the ones that appear narrow, it has to do with two things. One is we're not reading the QRS complex correctly, or it's just an artifact of how that lead looks. Now, if you're really stumped, in fact, even if you're not really stumped, forget about looking through the whole thing. The best way, and this is one of the most useful things on the printout, is always has the QRS duration. And that is super useful. You can just jump over, you can, I hate to say it, put your calipers back in your pocket and look at the printout and say, is this wide or narrow? So for example,
It'll pick out the widest one.
it will give you the accurate one. So I don't want to go into it now, but even if we went back and looked at that first one and I said, oh, this is narrow, if you knew how to read that QRS, it's actually a wide QRS. It's just, what's happened is that the S wave has been flattened out and you can't see it. So it looks narrow. Okay. So QRS, wide or narrow?
Narrow.
Narrow, yeah. Okay. That is 0.08. I'm not sure if you can see the numbers there. It's hard to read. Is it 8? I know, that's what it looks like, but it's actually, maybe it's, no, it's 0.088. No, it's 0.08. Anyway, wide or narrow? Yeah. Okay. So that's something very useful. And later on, not right away, but later on, by the end of this term, even if I don't give you the whole printout, which I don't give you the whole printout, I will give you the QRS duration, because I don't think it's a worthy use of our time to sit there and try and figure it out when in real life we can just read it. Okay, not yet. That comes in about 6 weeks. Now, what determines? Sometimes you'll see a QRS and it's mostly positive. There's a great big R wave. Sometimes it's mostly negative or equiphasic, meaning that the R wave and the S wave are equal. You know, there's as much above the isoelectric line or not. And when we look at the 12 lead, one of the kind of interesting things about it is you can kind of see how the QRS, so for example here, it's, you know, mostly or almost entirely positive, but here it's entirely negative, okay? So we already know that the morphology of the QRS in a specific lead is related to the main wave of ventricular depolarization. A huge simplification, you know, it's such a big simplification, it wasn't quite a lie, but it was a big simplification that we said, or I said, in the fall, was that mostly the main wave of depolarization goes from upper right to lower left. And as talked about as a simplification, that's not bad. But you can see if this is the direction it goes, lead 2 is going to be mostly positive, right? Because it's going right toward the eye of lead 2. Whereas lead 1, or AVL, is going to have a completely different shaped QRS because it's looking at it from a different direction. So it's no surprise that the QRS morphologies are different. Okay, this is still true, but this direction can be mostly variable. And in fact, something we're going to talk about probably in 2 weeks, is something called the cardiac axis, which is actually the actual direction in a particular patient of which way is that main wave of depolarization actually going. You know, we said, oh, it's a generalization from here to there, but if we look at specific people, it can vary widely. In truth, we consider anything, when we talk about that main wave of depolarization, we say anything that goes in any of these directions is considered totally normal, okay? So that's a very different picture from our original one in the fall where I said, oh, it just all goes that way. That's not really true in many cases, but anything there is normal. The direction is called the axis of the heart, and we're going to learn about that in a few weeks. Okay. So, what's a contiguous? What does the term contiguous mean? Who knows what that means? Contiguous.
Two beats that are in that same group, like to their lateral.
You're correct. But let's just talk about, if I said to you, oh, Oregon and Washington are contiguous states. What does that mean? They share a border. So the term contiguous, aside from the medical terminology, simply means, in sort of common parlance, simply means sharing a common border. So synonyms are adjacent, neighboring, adjoining. So that's what contiguous means. Now, here's what's important about contiguous leads. When we say two leads are contiguous, meaning they share a common border, we're not talking about on the paper. We're talking about in the heart, okay? So let me show you what I mean. So if we look at this, there are 3 contiguous leads near the bottom. What are they? Say it again?
3 AVF and 2.
Yeah, 2, 3 AVF. Those are the inferior leads. We think of those as contiguous leads, not because of how they're laid out on a 12 lead, because we can actually do that any way we want, but the fact that these share borders on the heart itself. The area that lead 2 is looking out on the heart is just adjacent to AVF, just adjacent to 3. So these are 3 contiguous leads. Okay. Now, if we talk about, anybody remember 1 in AVL? What are those considered? We know they're not inferior because we just did inferior. Say it again?
Lateral.
Yeah, these are the high laterals. And again, these are considered contiguous leads, not because of how they don't actually lay side by side on the 12 lead itself. But if you look at what area the heart is lead 1 looking at, what area the heart is AVL looking at, it's borders, it's areas that are adjacent on the heart. Okay? So let's look at the limb leads and talk about what the contiguous leads are. So just the limb leads, just the left side, is these are considered contiguous leads. Okay? Because remember what we're going to learn next week. What's the definition of a STEMI? How do we find a STEMI? 2 or more what?
ST elevation and 4, 5,
Say again?
6.
ST elevation in what?
3, 4, 5, and 6.
2 or more contiguous leads. ST elevation in 2 or more contiguous leads. Well, if you're going to find a STEMI, you have to know what the contiguous leads are. Okay? So our first, the inferiors, which by next week, if I say inferior, you'll go, oh, 2, 3 AVFs. Those are contiguous leads. 2 is contiguous with 3, contiguous with AVF. Meaning that if we see ST elevation, for example, in 2 and 3, those are contiguous leads. It's going to be a STEMI. I mean, there's more to it than that, but that's the beginning. Okay? The other contiguous limb leads are 1 in AVL, because remember, those are both up here looking at the high lateral wall of the left ventricle. So 1 is contiguous with AVL. Now, is lead 1 contiguous with lead 2? It's lying right beside it on the, it's not, okay? Lead 1's up here, lead 2's down here. But don't get confused. Don't say, oh, they're contiguous because they're sitting right beside each other on the 12 lead. That's not what we're talking about. We're talking about on the heart itself. Okay, again. Okay, and actually, I mean, we haven't started talking about ST elevation, but do you see any ST elevation there? Where? Yeah, tiny bit in 2, 3 AVF. Are these contiguous leads? Yeah. So this is, again, there's more to it than that, but this is the beginning of your saying, oh, I think there's a stemming, I think there's an inferior stemming. And then 1 in AVL. Okay? Now, AVR is not contiguous with any other lead. Okay? So we never include it with the stemming. But it does have kind of a special relationship with lead 2. Here's lead 2, and almost directly across the circle is AVR. So what that means, if this is lead 2, AVR is just going to be an upside down version of it. And that's kind of a good thing to know. So if the P wave is upright in lead 2, what's it going to look like COA? What's it going to look like in AVR? Yeah, it's going to be flipped, okay? If there's a big R wave in lead 2, what are you going to see in AVR? A big what wave? What's a negative wave?
Or Q.
An S, probably an S wave, because there's a little tiny Q here, and so on. So, okay, so what we'll see is a flipped P, a flipped T, and a little tiny R, which was the Q in lead 2, and an S wave. Okay, so if we look, I just, sort of grabbed any old, if we look, there's AVR, there's lead 2, and you can see how similar, not precisely the same, but how similar they look. They're just flipped versions of the other. Okay, here's another one. Again, just a flipped version. Okay. Now, when we're talking about contiguous leads, I think we've got it all wrapped up in the limb leads. What about those V leads? So remember, the way the electrodes, it's V1, V2, V3, V4, V5, V6. They're just like that. And they're all contiguous with each other, meaning that V1 is contiguous with V2, V2 is contiguous with V3, V3 with V4, V4 with V5, and V5 with V6, because it's just one big territory that it's moving across. Okay? And then finally, what always is a little goofier, the lateral. So 1 is contiguous with AVL, contiguous with V5, contiguous with V6. Okay? Okay, I'm going to go through the next 8 slides pretty quick. Okay? I'm going to talk about something that doesn't matter to us, but it's in every book, and you're going to hit it. And what I'm going to say is this is what it is, and I don't want you to worry about it. Okay? So you will not be tested on the next 8 slides. In fact, if you want to take a little snooze for 8 slides, that's okay with me. Okay. Here are the V leads. There is something called good R wave progression. Okay? Something called poor R wave progression, which is abbreviated PRWP. W to the okay, this is good R wave progression. This is V1, V2, V3, V4, V6. And if you look at what's happening, V1 typically is mostly negative. V6 is mostly positive. And it has to transition from one to the other. So it gradually gets less negative, more positive, less negative, more positive, more positive, more positive. That's what's known as good R wave progression. QRS and V1 should be mostly or completely negative. The QRS in V6, mostly positive. And then V3, there's this transition that happens, and usually the transition happens in V3, meaning that's where it's equiphasic, that's where it's equally positive and negative. That's considered a good R wave progression. Here is the famous PRWP, the poor R wave progression. And if you look at the R waves, they just don't progress. They just sort of sit flat. Poor R wave progression, you do not need to know this, is defined as the R wave in V3 is less than 3 millimeters. So I'm telling you what it is, so when people talk about poor R wave progression, you know what it is. But the reason I don't think it's worth, and you can memorize it if you want, I don't think it's worth your time. And the reason is because there's so many different reasons for poor R wave progression. Okay, this is not an inclusive list. So you have somebody with poor R wave progression and you think, wow, I wonder what this could be. It could be an old MI. If it's an obese woman, maybe I put the leads on wrong. Oh, is this a left bundle branch block, left ventricular hypertrophy? What if they have WPW? What's dextrocardia? Anybody know? Dextro, what does that mean? Anybody remember? Cardio, what does that mean? Heart. Dextro is right. It's people who are born with a heart on the right side. And it screws up the 12th lane. Tension pneumophagy. So that's why I don't think it's useful. It's so non-specific. Okay. We'll talk about P waves, then we'll take a really brief, truly just a really brief 5-minute break, and then come back and see if we can get finished up. Okay, P waves. What's normal for a P wave in lead 2? Upright. Not only does that not change, but it's still your most important lead for P waves. Sinus P waves will be upright in leads 1, 2, AVF, V4 through V6. You truly don't have to memorize all that, I don't think. They will be inverted in AVR, because remember, 2 and AVR are like upside down images of each other. And then all the rest of it, who knows? They can be upright, they can be inverted. The big thing to remember with this, lead 2, this doesn't change. It's still the most important lead to determine if P waves are sinus P waves. AVR is also important. Suppose you can't see the P waves here, then you have to start looking other places. Okay. So upright in lead 2, plus a nice little extra inverted in AVR, think sinus. So that has not changed. Now, what about, if you look here in lead 2, they're pretty clear P waves, right? In lead 1, there's pretty clear. But we start looking around, in V4, there don't appear to be P waves at all. There don't appear to be P waves in V5. So is this a sinus rhythm or a junctional rhythm? Okay, what do you do about this? So here's the answer. The P waves are there. They are real. Just because they're not visible in some leads, it doesn't mean they don't exist. It just means they don't show up in those leads. So if you see good P waves, even in just one single lead, there are P waves. Okay? And sometimes you have to search. Remember I said one of the use of a 12 lead is to determine rhythm interpretation. And suppose you're looking at it and you're thinking, oh, I don't think I see good P waves in lead 2. Maybe this is a junctional rhythm. Don't give up on sinus until you look at all the leads. A little tip is that if you're looking sometimes for good P waves, like hard to say. Are those P waves for the first degree AV block? Maybe, it's probably what it is, but I can't really tell. Lead 1's no help. AVR is not much help. V1 can sometimes be your best, not always, but sometimes be your best lead when you're looking for P waves. Because it's right on top, it's right near the SA node, right near the right atrium, okay? So in this particular case, oh yeah, it is P waves with the first degree AV block. Now I can go back and say, yeah, these are P waves for sure. So when you're searching for P waves, look at every single lead, but sometimes V1 is the best. Okay, real quick. So the SA node, what is it in, the right or the left atrium? So Grace, right or left atrium? Right, okay. So, and remember then, there's that Bachman's bundle that goes across to the left atrium, depolarizes. But what that means is that the right atrium depolarizes a fraction of a second before the left atrium. Not by much, but a tiny, tiny bit. So if we are looking at the makeup of a P wave, this is what it looks like. But what's really happening is the right atria and the left atria are depolarizing just a tad out of sync. So the front, in a healthy heart, the front side of the P wave is the right atrium and the back side is the left atrium. And it doesn't matter that much, that's not so important. But there's a couple things that are useful. Number one, what is really common in V1, and it's going to confuse you unless you know that it's common. So this is important to know. I know I'm going to be asked this all term. People are going to say, why is there a biphasic P in V1? And the reason is, in V1, okay, what's happening is, here's V1, is the right atria depolarizes and it's going toward V1, but then the left atria depolarizes and it goes away from V1. So what that means sometimes, frequently actually, is the P wave morphology in V1, right atria depolarization, left atria depolarization. Even if you don't remember the reason, even if you don't remember, oh yeah, right atria, left atria, it is very useful for you to know that the P wave in V1 frequently is biphasic, positive, negative. Because otherwise it's going to confuse the heck out of you. You're going to think, I don't know what's happening here. But it's perfectly normal. So for example, here's an example. Right atria, left atria, positive, negative. Okay, this is V1. Okay?
Kate,
Yes.
would it be just as common to have an inverted P wave in V1 for that same reason?
It's possible to have it. Typically what's happening there is the right atria is just not, the particular way that the electrode in the right and left atria line up. I put it this way, if I saw an inverted P in V1, but we still had a positive one in V2, I would still think silence. I would think, okay, I'm not quite sure what's happening here. For some reason, the right atrial depolarization is not popping up with what I saw up.
Right.
So it's possible.
Okay. Real quick, we'll do this and then take a quick break. You know, in the fall, we started off and what your textbook said is a normal P wave looks upright, not too large, nicely rounded, and so forth. And I said, forget about that. All we care about is upright. Okay, we don't care about the nicely rounded. But now it's kind of useful to know, well, why are some P waves odd looking? Why are some enormous? Why do some have little divots in the top? So we're going to kind of go through it kind of quickly. Sometimes one atrium becomes enlarged. It's the right atrium, we call it right atrial enlargement. It's the left atrium, we call it left atrial enlargement. And because we now know that the P wave is actually made up of two different depolarizations happening at the same time, we know that if one of these atria is enlarged, it's going to change the shape of that P wave. Okay? So in right atrial enlargement, the atrial depolarization lasts really long, and it sort of engulfs the left atria depolarization. And what tends to happen then are big P waves. So if you see unusually large P waves, it is very probably because of right atrial enlargement. Does this matter in an acute setting? Not particularly. This is not the most relevant piece of information I've given you this morning. But it is kind of useful. You're going to be looking at these things. And I know you've wondered before, because in the fall people would ask me and I would say, it doesn't matter. But that's the main reason for a large P wave. Now, left atrial enlargement, what happens is that the left depolarization goes on for a long time, and what we end up with is, here's a normal, this is left atrial enlargement, normal right atrial depolarization, abnormal left atrial depolarization, and that leads to a notch. And I know we've seen these. I know you've seen these. So for example, this is left atrial enlargement. So if you've wondered up to this point, why is that P wave so funny looking? That's why that P wave is so funny looking. This is how I remember the difference when I'm looking at a P wave and I know it's some kind of atrial enlargement, and I'm trying to remember, which one is right, which one is left. This works for me. It's kind of goofy, but it works. So what I do is I say the P wave in left atrial enlargement looks a little bit like an L, and that's how I remember it. So if you have interest in remembering it, and that works for you, that's it. And then here's a summary. Lead 2, normal. Right atrial enlargement, left atrial enlargement, both, I don't care about that. V1, okay? But again, probably the most important part of this, aside from normal sinus, upright lead 2, is biphasic is normal in V1. Because I guarantee you, otherwise it's going to trip you up. You're going to look at it and think, something's happening, I don't know what it is. So that's the most important. Let's see, how close are we? We're going to go for another 20 minutes. Do you want to take a few minutes break, or do you want to just barrel on through? Take a few minutes break. Okay, let's come back let's 5-minute break, so 10:53.
I'm gonna have some like PTSD. I'm gonna have to get through to be in there.
Yeah, that'll be
How old is he now?
14 months.
Okay, let's finish up here. So our last two topics, which are both pretty short, are rhythm interpretation and ST elevation and depression. So this is a slightly complicated process. So what about interpreting the ECG rhythm from the 12 lead? And of course what I mean is it a sinus, is it a junctional, an AFib, whatever. So just using the 12 lead, sometimes it can be tough, because remember you only have 2.5 seconds per lead, and then it changes shape. So sometimes it's easy, sometimes it's hard. And that's why when you have a hospital 12 lead, that's why they run off these rhythm strips across the bottom. Like, I think it's, they can do anything they want, but in my experience, which to be honest in a hospital is not fast, but they almost always do a lead 2. And that's because that's our best one to see, oh yeah, look, it's a sinus rhythm, okay? Now, again, here's another one. If you look at this, again, it can change really drastically. Like, what's this? Oh, I don't know. You can see how much it changes across. But if you can run rhythm strips across the bottom, which tells you that generally speaking, people are not actually using the 12 lead part of the 12 lead to determine the rhythm. They're using the rhythm strips across the bottom. Okay? Now, we don't have rhythm strips across the bottom, so what do?
Print out
Say it again?
leads, print out a couple of leads.
Yeah, usually what we do is before we even get the 12 lead, we know the rhythm, because what we do is we first put on the initial electrodes and then we run off a strip and somebody says, oh, look at this, it's wandering atrial pacemaker. Okay, then we do the 12 lead. And one of the reasons, at the near the end of our 12 lead part, I'm going to give you the formula that I use when I'm analyzing a 12 lead, but one of the reasons I don't really like the ones that you get out of 12 lead books is they always say at the beginning, like the first few steps are rhythm, rate, and axis usually. Well, for us, we usually get the rhythm before we do the 12 lead. We get the rate before we do the 12 lead. And even though I'm going to teach it and you're going to know how to do it, I don't think the axis is a very useful thing for us. So there's plenty of, in 12 lead references, there's plenty of like steps of analysis, but I personally don't think they're really useful for pre-hospital. So that, you know, you can explore and see if it's useful for you. But again, for us, most of the time, we already know the rhythm before we get the 12 lead. That being said, the National Registry is a bit of a oddity. And to be completely honest, I don't know, because we never can get information about the National Registry. I don't know if they still are doing this, but in past years, for the dynamic cardiology, they would give people 12 leads, no printout, no strip across the bottom, and expect them to say what the rhythm is, which I think is stupid, because people in hospitals don't do that. They use the rhythm strips across the bottom. Pre-hospital, we don't do that because we run off strips. However, you need to be able to do it for that reason. That's the only reason. So one of the things I'm going to ask you to do during this course, as I'm going to try to remember to ask you, is say, look at this 12 lead, just from the 12 lead, say what the rhythm is. And most of the time you'll be able to do it, okay? It's just easier if you have a 6-second strip or something. Okay, new topic about it is every once in a while, it's really hard to tell what the rhythm is from lead 2, you know, when we print out a strip. And the 12 lead is actually going to help you decide what the rhythm is. And here's a very good example of that. What's this? This is lead 2. And I'm looking at it, kind of scratching my head and saying, I have some ideas, but I'm not entirely sure. I think maybe this is a PVC, but that's the only thing I'm sure of. This is a really hard strip. However, if you put it into the 12 lead, all of a sudden, you know, the clouds are going to part and the sun's going to come out. If you look at it, look at lead 1. What is it? Yeah, a normal sinus. But lead 2, which is usually our stalwart, you know, what we use to determine, it's really let us down here, okay? Now, I'm going to show you a trick now that you'll be able to, if you remember, you're going to be, and we'll talk about it more, you'll be able to use at different times. Remember, this is all continuous. So I am actually pretty interested to know what's what here. What's the P wave, what's the T wave, what's the QRS? So what you can do in a situation like that is drop a line down. Well, this is clearly the P wave here, right? This is clearly the P wave here. Comes right down through this. Huh. Now I know what the P waves are, right? This is a P wave, this is a P wave. See how it lines up? It's happening simultaneously. Then what I'm going to do is drop a line through the QRSs. Oh, look at that. This is the QRS. Who knew, right? So this is the P wave, this is the QRS. I never would have thought that, okay? So sometimes when you're trying to sort of figure out what's happening, remember you can always go up work down and look at what's happening in another lead at the same time. That's a really useful little trick. Okay, our last bit here, and then we'll go home, or go wherever, go to lunch. ST elevation and depression. Last term, we really didn't care about ST elevation and depression. Now it's kind of our bread and butter, okay? So when we begin our search for STEMIs or other signs of ischemia, one of the things that you will be doing over and over again is to go through the 12 lead and look for ST elevation and ST depression, okay? And it really pays to do that most of the time in a very systematic way. Don't just jump and say, oh my God, there's ST elevation in the inferior leads, I got an inferior STEMI. It really pays to be very systematic, go lead 1, lead 2, lead 3, you know, and mark where the elevation and the depression is. Now, we mentioned this very briefly last term. Let's see if anybody remembers. It really wasn't that big a deal. When you take your straight edge and you lay it across to see if there's ST elevation, what do you line the straight edge up with?
The main line.
Well, the isoelectric line, but what part? No, because the J point, if there's ST elevation, it's going to be high. If there's depression.
PR.
That's a really good answer, but it's not right. Okay? So that's your second best place. The best place is the TP segments. Anybody remember what the TP segments are? Where do they start? Where do they end?
End of T, beginning of P.
The end of the T to the beginning of P. Okay? This is your most reliable part. End of the T to the beginning of the P. The PR segment, sometimes there isn't a good TP segment, and then you have to fall back on the PR segment. But sometimes the PR segment can be depressed. Pericarditis, there's PR depression. And so the TP segment is the more reliable thing. So if you want to know if there's ST elevation, take a straight edge. Don't eyeball it because you'll miss the subtle stuff. And you just do your best to lay it across the TP segments. Now, when I say do your best, I mean exactly that, do your best. Okay, these are pretty easy, but they're not all, what you're going to find is it's not always easy. This one is really easy, the first one, because the TP segments are pretty flat. Here you can see they kind of all have this sort of down, they're not perfect, but you just do your best, okay? Now what some people do, and I don't recommend it, is they take the straight edge and then they draw a line, which essentially is what I've done here, but that's because I'm showing you on the projector. The trouble with drawing a line is that some of this stuff is really subtle and your line has a certain thickness to it. And so sometimes you can, it hides what you're trying to see. So I don't recommend drawing the line. Just use your straight edge. Okay, so lead 1, Riley, is there any ST elevation or depression?
Doesn't look like it.
Doesn't look like it to me either. Okay. Grace, what about lead 2?
Yeah.
Okay, which one? Elevation or depression?
Elevation.
Yeah. And, oops, sorry, I went the wrong way. And specifically, one of the things that if you're calling in a report on this patient, one thing you might say is, oh, there's 2 small boxes of elevation in lead 2. So more boxes is worse, okay? More elevation is worse. And then, Natalie, what about lead 3?
Yeah.
Yeah. Okay? Okay. So, let me see where we are here. Okay, we'll do 1, and then I think we're going to call it kind of call it a day. So, Anne, you can always move up if you can't see it. What I want you to do is, now, the most important part of the ST segment is the J point. So if you have an ST segment that is not flat, just look at the J point. What we're really asking is the J point elevated or depressed, okay? So what I want you to do is go through and just do lead 1, lead 2, lead 3, you can skip AVR, AVL, AVF, etc. And just say, all you have to do is say elevation, depression, or nothing.
So 1 is slightly depressed.
I agree.
2 is elevated, 3 is elevated, ABL is depressed, ABF is elevated.
Okay.
1 is depressed, 2 is depressed, 3 is depressed, 4 is elevated.
Maybe, yeah. It's like maybe
5,
nothing. Yeah.
86 is elevated.
Okay, so, what you're going to do, okay, is for your homework, you'll see under homework, I think it's just listed as homework, it's also in your to-do list, is you're gonna practice with this. So get some kind of straight edge, okay? And the answers are given, so you can check yourself and, print them out and just go through and do it really systematically. Is it elevated, depressed, or nothing? And remember, the critical part is the J point, okay? So, questions? We're done.
You are the most consistent teacher we have. Very appreciated.
Oh,
Like, you tell us what's expected, and your website is so clear.
Thank you.
Always posted on time, so
Thank you.
thank you.
Thank you.
Thanks.